Hello my friends, Dr. Kazmi once again here, and in today's video I'm going to talk about pediatric headaches. And before I dive into today's topic, for those of you who are watching my channel for the first time, please do subscribe to my channel, and if you like my videos, do share it and also comment. So without further ado, let's get straight into our today's topic, that is pediatric headaches. So pediatric headaches, well, it is the headache simply means it is pain in the region of head and neck. So if you've got pain anywhere around this region or this region, we call the head and neck region, that is classified as headache. Now the mean prevalence is somewhere between 24 to 90%. It simply means it varies a lot. I mean, depending on the populations, depending on the age groups, it could be like 1/4 of the population at any given time can suffer from headaches, or it can be as high as 90%. Like 90% of the kids in the pediatric age group have like reported that they have suffered from headache. The mean, if we take the average, that is around 58.4% of the children, they do complain of headaches. Now the prevalence before adolescence is equal in boys and girls, but after puberty, for some reasons, girls have more tendency to report and suffer from headaches as compared to the boys. And again, if we take the primary headaches, and I will come in a moment what are primary headaches and what are secondary headaches. Primary headaches are generally more prevalent as compared to secondary headaches, which have got their cause somewhere else. Now, as far as classification is concerned, we classify headaches into two types: primary headaches and secondary headaches. Now, primary headaches are basically and primarily physiological functional in nature. So you do not have any organic reason for these headaches. It could be because of generalized tension, anxiety. Migraine is also classified in this type of headache. While the secondary headaches are basically headaches caused by something else going on somewhere in the body. For example, if somebody is suffering from hypertension, because of increased blood pressure, they are suffering from headache, or if they've got any other reason which is actually causing headache as one of the symptoms, then we classify it as secondary headaches. As far as this classification is concerned, where does this classification comes from? This comes from the International Classification of Headaches, and the third edition, which was a beta edition, I think, if I'm not wrong, this was back in 2016. And there is when they have divided these headaches into primary headaches and secondary headaches. And there is a third category as well, which are like facial pains and some other form of headaches or pains around in the head and neck region, which do not fit either into the primary or the secondary category. But anyhow, for today's lecture, I'm not gonna go into the details of that third category. I will be primarily focusing on the primary headaches and the secondary headaches. Now, the primary headaches primarily they are migraine and tension headaches. There are a few other types like what we call trigeminal autonomic cephalgias, but anyhow, they're quite rare. So I will focus on tension headaches and migraine for most part of my lecture. Secondary headaches are headaches that can be attributed to any other organic problem, and the list is quite an exhaustive one, and I will try to focus on some of the common ones. But anyhow, for sake of simplicity, just remember primary headaches, no functional, no organic cause, they're just functional in nature, and secondary headaches when there is a reason, and headache is primarily a symptom of something going somewhere else in the body. The same international classification of headaches, and this chart is actually taken from Tintinelli's Emergency Medicine, the 2020 edition, and that has given a very good further subdivision of the primary as well as the secondary headaches. And they say primary headaches, which I told you earlier, primarily they are composed of migraines and tension headaches, and how they are further subdivided and what is the diagnostic criteria for these types of headaches. So migraine, they have divided it into four types. Into three types. One is migraine with aura, one is migraine without aura, and the third one is where you think it is probably a migraine because it's not fitting into one of the earlier categories of migraine with or without aura. So let's go into what is migraine with aura, without aura, and what is a probable migraine. Now they've got like strict criteria. The diagnostic criteria for migraine without aura, which is more common as compared to the migraine with aura, is that you need to have at least 5 attacks. So there must be a history of 5 attacks in the past. This is very important. That's why if somebody has got a prolonged history of these types, then the diagnosis becomes easier, because then you can fit it into this diagnostic criteria. But obviously if somebody has got first or second attack, then probably you don't know, and you will put them in the third category, which we call as the probable migraine. Nevertheless, anyhow, so you need to have at least 5 attacks in the past, and then you should be having some more features. Number one is that the headache itself can be of a duration which varies between 2 hours and 72 hours. This is important. It could be a short lasting headache just for 2 to 3 hours, or it could be a long lasting headache where it goes on for 3 days, almost 72 hours. And there should be at least 2 of these following 4 things. So it should be unilateral, it can be pulsating, it can be of moderate or severe intensity, and the 4th thing is that headache is made worse by activity. So any 2 of these 4. So you can have a unilateral and pulsating headache, or you can have a unilateral moderate intensity headache, or you can have a pulsating headache which is made worse with activity, or you can have a moderate intensity headache which is made worse by activity, but there's no unilateralness, there is no pulsation. I mean, it's just generalized headache. So you see there's a bit of variation. So if a person has got 5 attacks, or a child has got 5 attacks in the past, and the headache duration is between 2 to 72 hours, and he's got any 2 of these 4, that is unilateral, pulsating, made worse by activity, and moderate or severe intensity, you classify it migraine without aura, because there is no aura. There's like, aura is a sort of a strange sensory phenomena which can be visual in nature, it can be autonomic in nature, it can be sensory in nature. So I will come to that in a moment. Like migraine with aura, they should have at least 2 attacks in the past, and they should be having 1 or more reversible auras. Like it could be visual in nature, it could be sensory in nature, it could be they can have disturbances of speech, they can have disturbances of motor system, like weakness in one part of the body, so on and so forth. And at least they should have 3 of the following 6 things. Number 1, there should be gradual spread of aura, that is spread over greater than 5 minutes. There should be 2 or more symptoms that can occur in succession. The individual symptoms, they can last anywhere between 5 minutes to 1 hour. At least 1 symptom is unilateral, 1 symptom is positive, and it is accompanied or followed by headache within 60 minutes. Now, positive symptom is, it simply means that these symptoms are not present when you are normal, but these symptoms, they come when you have got this aura. For example, you are otherwise normal and all of a sudden you see flashes of light. So you don't see it when you are normal, but when there is a beginning of this migraine with aura, you start seeing flashes of light. And that is a positive symptom. Or it could be strange sensory perception. You feel like your skin is very sensitive to touch all over the body. Or you can have a motor symptom. You all of a sudden you feel like your part of the body, like part of the arm or limb, it starts becoming weak. Or you can have speech disturbances, like you want to say something but you can't talk properly. You are talking gibberish, or simply the words are not coming out of your mouth. So speech disturbances, which are not normally present, but when the aura comes in, you have these things. So one of these positive symptoms should be present. So if 3 of any of these things, that is the gradual spread over more than 5 minutes, 2 or more symptoms are occurring in succession, like flashes of light followed by speech disturbances or by motor weakness, anything, and 1 symptom is unilateral, like it's not like where you, like for example, you can have the strange sensation like hypersensitivity to touch all over the body, but then you might have a limb disturbance on the left or the right side. So that is unilateral phenomena. So one of the symptom is at least unilateral. So if somebody fits this criteria, then we call it he's got migraine with aura. Again, as I said, like you need to have all of these things to diagnose somebody comfortably that they have got migraine with aura. most of the people like who are turning for the first time with these symptoms where there's no past history of, let's say, 5 attacks for migraine without aura, or 2 attacks with aura, then it becomes a bit difficult to actually give them this label of being suffering from migraine with or without aura. So we have got the third category, which we call as probable migraine. So probable migraine is that the attacks are fulfilling all but number one, that you of the criteria for migraine without aura. That, in other words, you've got a unilateral pulsating headaches, but you don't have a past history of 5 attacks. This might be the first or the second attack. And the same goes for migraine with aura. You don't have a past history. It might be your first one. So if somebody is coming for first or second attack, then usually you put them in probable migraine, because you need to have at least 5 attacks for without aura and 2 attacks with aura to classify them or label them with migraine. So if they are presenting for the first time, you will just label them as probable migraine. So if they've got a past history and they fulfill, so either you put them in the bracket of migraine without aura, migraine with aura, or somebody who's presenting for the first or second time with these symptoms, you will say probable migraine. Now this is how you will put them in one of these categories of migraine. And migraine is part of primary headaches. The other major category within the primary headaches is what we call as tension type headaches. Now again, for tension type headaches, the International Classification of Headache Disorders, it says that you should have at least 10 episodes in your past medical history. So 10 episodes of headache, and these headaches can occur or persist for less than 1 day per month, which we call as infrequent, if somebody is having just like less than 1 day of headache per month. Or it could be very frequent, where you can have at least 1 to 14 days of headaches per month for at least 3 months. So you see, there is a lot of variation. Either you can have infrequent headaches, just 1 episode per month, or frequent one, where you can have at least 14 episodes per month. So you should have at least 10 of these episodes, number one. Number two is how long the headache should be lasting. Again, it can last anywhere between 30 minutes, half an hour, to 7 days. So you see a big margin here. You can have a short lasting headache where the headache persists for, let's say, 30 minutes, 1 hour. You took some paracetamol, it went away. Or you have been taking medication and it still persists for almost a week. So 10 episodes, duration of headache anywhere between half an hour to 7 days, and at least one of these 4 things. It should be bilateral. Now, unlike the migraine where we said it could be unilateral, this one is bilateral. So you've got like pain all over the head. It's bilateral. It's usually non-pulsating in nature. So it's more of a sort of a pressure or a band around your head, that nature of headache. It's of mild or moderate intensity. It never goes to the severe one. And it's not worsened by routine activity. And this is very important, because the point I want to make here is one of the things that you should be asking when somebody who presents like in the pediatric age group and they present with headaches, and I'm not talking about the headaches which have got a secondary reason, like somebody's having high temperature and they've got headache, or somebody's got meningitis and they've got headache. I'm talking about primary headaches where there is no other reason. It's probably functional in nature. So you need to ask those headaches whether they are made worse by activity or not. So if they are made worse by activity, that goes more in favor of migraine. If they are not worsened by activity, it goes more in favor of tension headaches. And also keep it in mind that there should be no nausea and vomiting, and there should be no more than one, like photophobia or phonophobia. So remember, tension headaches, they never have nausea or vomiting. If nausea or vomiting occurs with headache, it goes more in favor of migraine. If they've got photophobia or phonophobia, that they don't like bright lights or they don't like sounds or people talking, goes more in favor of migraine rather than headache. So please keep it in mind that these are some of the clinical things which can give you an idea whether this child is fitting into the category of migraine and whether he is fitting into the category of tension headache. So please keep this in mind. Moving on, secondary headaches. Secondary headaches means that they've got some reason somewhere in the body. And again, the list is quite a big one. Infectious reasons, trauma, vascular reasons, neoplastic or growths, some toxidromes, some systemic disorders. Anyhow, just quickly going through that list, like infections where you have got fever can be associated with headaches, like meningitis, encephalitis, or intracranial abscess. These are life-threatening, and some of the common causes that can give you secondary headaches with febrile illnesses, usually your upper respiratory tract infections. Trauma, very common. Children less than 5 years of age, they do, or even less than 10 of years, the head injuries are quite common in them, like playing around, bumping their head into some object, or falling down and getting bruise on their heads can lead to headaches, and that's quite common. The important thing is to rule out if the mechanism is severe, and NICE has got the guidelines for that. Obviously, if somebody's got severe headaches after a trauma or something, then you should be thinking of traumatic intracranial hemorrhages, or you can think of skull fractures, things like that, but that's altogether a different domain. Vascular phenomena which are a bit rare in the pediatric age group: intracranial hemorrhages, hypertension, not that common, stroke, etc. Once in a while you can see them, but obviously they are quite obvious because you will find a high increase in blood pressure, and there will be something in the past medical history or in the associated symptomatology which should guide you in this direction. Growths, obviously, brain cancers, medulloblastoma, astrocytomas, glioblastomas, all types of growths, whether benign or malignant one, they can cause headaches. Toxidromes, like some of the toxic exposure, especially carbon monoxide, especially if they have been burning wood and there is a history of other family members having headaches at the same time. Think of carbon monoxide exposure. Some of the heavy metals can also cause those. It's a bit rare these days. In teenagers, also think of cocaine, especially if they've got dilated pupils and the history is dodgy, and let's say they are known to social services, or they're looked after, or the associated social history is such that where you can think that then can be some association with gangs and other things, then you think of these like toxidromes as well, especially exposure to these contraband drugs like cocaine and some other things, weeds, etc. as well. Systemic causes, SLE, vasculitis, etc. can also give you headaches. And in obese teenager girls, sometimes if it is associated with some visual disturbances but no other cause is found, idiopathic intracranial hypertension is one reason. And then there are a few other things like temporomandibular joint dysfunction, postictal headaches. Sometimes your glucose levels are down, you can have headaches, we call the hunger headaches and things like that. But anyhow, so the list is quite a big one. I just tried to focus on some of the common things, but again, as I said, secondary headaches are a bit easier to diagnose because usually if you get a good history, you will come across the points which can point you in the right direction and you can find the cause for it. Some of the red flags in secondary headaches, again, if somebody has got a headache which is what they call the worst headache, thunderclap headache, all of a sudden, even if they've got a prior history and they say, well, this headache is unlike anything else that they've suffered in life, so that is a red flag. You can think of subarachnoid hemorrhage, and a CT scan or lumbar puncture should be on the card. So obviously these kids, they need to be investigated, they need to be admitted, and then you can do the workup. Similarly, headaches which occur early in the morning, somebody wakes up, and especially if they are occipital in region, and especially if it is associated with vomiting or some motor weakness or something, that is also a serious red flag, and that could mean an increase in intracranial pressure for one reason or the other. And obviously they need to have a workup, at least a CT scan, or even later on you can do an MRI as well. Similarly, those people with headaches who have got altered mental status and they've got vomiting and they've got fits or something, again, that is also a red flag. You should think of underlying central nervous system infections, or encephalitis or meningitis, and again, they need to be admitted, and our appropriate workup needs to be done for that. So remember, severity, sudden onset, very severe headache early in the mornings, headache which is associated with vomiting and neurological symptomatology, or headaches which are associated with altered mental status, or headaches which are associated with sudden loss of vision, like giant cell arthritis, things like that, you should take them very seriously, and these kids need to be admitted and they need to be worked up. You cannot simply send them home that, well, it's just a bad headache and they should take just painkillers and it will go away. No, they have to be admitted. A proper workup has to be done, and you can only send them home if you rule out all these serious causes. That's the point that I wanted to make, that you should be very much wary of the red flags. So always look for the red flags in any child who presents with headache. Temporal patterns are also important because temporal patterns can tell you, like for example, if somebody had fever and then they had got headaches and they had upper respiratory tract, obviously you know that this is a febrile headache caused by common viruses. Similarly, if somebody has got, in the past medical history, they have a history of headaches with vomiting, abdominal pain, pallor or nausea, and then in between they're fine, and there's a repeated history where they've got like symptom-free intervals in between, that goes more in favor of migraine. If somebody's got a headache which is progressively worsening, I mean, it is there all the time, but like in a step-ladder method, it is worsening over let's say over the past few weeks or few months, that is also something that you need to look into, because there might be something, a progressive pathology going on, like progressive space occupying lesion, or small like expanding hemorrhage, anything. Similarly, something which is not progressing but is there most of the time, goes away for some time, comes back, goes more in favor of tension headache, especially if these kids are stressed out either because of their social circumstances or because of their school circumstances. There could be a variety of reasons for that. Anyhow, that goes more in favor of tension headaches. So temporal patterns, the way the headaches they came in the past, the way they responded to different types of treatments, the way they are progressing, it can give you a clue as to some of the possible reasons that is causing those headaches. Now, coming down to the point, how do we clinically approach the headaches? Now, it's very important. History and physical examination are the cornerstone of diagnosing the underlying reason for headaches. So good history and physical examination. So you need to ask, how did the headache start? What have been the aggravating factors? What have been the relieving factors? What have been the temporal patterns of headaches? If they had like previous episodes of headaches, have they got any other associated features like fever? Ask for any neurological symptomatology and do a thorough physical examination, which includes a proper neurological examination. And don't forget to do an eye examination. Look into the ears, look into the throat, and look into some of the local reasons in the headache and neck region which can cause headaches. Now, as far as the primary headaches are concerned, like if you go through this classification and if you fit somebody into primary headaches, no lab testing is needed from primary headaches. I mean, for migraine or for tension headache, if you are sure about it. Yes, if you are thinking about secondary headaches, then obviously some basic workup is required, because you need to know what's going on. So at the very basic level, I would understand that you will do a full blood count, you will look at the UNEs, you will look at the glucose levels, the ESR, renal function test, liver function test, and if somebody is febrile, you would do a blood culture, and if they are teenager and the history is dodgy, you would do a drug screen as well. If you are suspecting central nervous system pathology, you might consider doing an LP with CSF examination and opening pressures to see if there is any reason like idiopathic intracranial hypertension or meningitis. You can do a fundoscopy to see if there is papillary edema, because papillary edema can give you an indication that there is raised intracranial pressure. Now, as far as imaging is required, many times the parents, they put pressure, especially if the child has got repeated episodes of headaches. They say, well, the child needs to do CT scan or something. Please keep in mind that CT scan is not required for primary headaches. And even for secondary headaches, especially if your neurological examination is normal, because the yield is very low. please keep it in mind, the yield of CT scan in headache is low. If somebody's got headache and you do CT scan, yes, if there is a history of trauma, you do CT scan to rule out intracranial hemorrhage, or you can do CT scan to rule out fracture. But you don't do it to, like, let's say, even if you're suspecting an intracranial tumor, CT scan has got very low yield, because most of the tumors in children are infratentorial, and CT scan is not good in picking at that. So if you are suspecting a tumor, then MRI is what is needed, not a CT scan. So if there is a parental pressure on you that they are asking you for CT scan, if neurological examination is normal, tell them very clearly that there's no need, because even if you do CT scan, the yield would be very low, and there would be unnecessary radiation to the child, especially to the thyroid gland, and that can lead to problems later on in their life. So keep it in mind, CT scan has got a very low yield, and if a scan has to be done, that is MRI. Treatment, okay. First line treatment is always paracetamol and ibuprofen, and I'm talking about primarily the primary headaches, and even some of the secondary headaches where the headache is caused by a febrile illness. So paracetamol and ibuprofen. So paracetamol in 10 milligrams per kg to 15 milligram per kg. If you're giving rectal, you can go even up to 20 milligram per kg. Body weight ibuprofen 8 to 10 milligrams per kg per dose. We always say do not use narcotics for primary headaches. So do not use things like tramadol or any other narcotic like codeine or dihydrocodeine from primary headaches, because there is always a tendency for these drugs that the children can get addicted to these narcotics. So never use these things. Ketorolac is a very effective drug if used parenterally, not orally, like parenterally, but it is less effective than prochlorperazine. So, but prochlorperazine is very effective if your first line treatment fails, like ibuprofen and paracetamol. Then prochlorperazine, Stemitil as it is known in some countries, is a very effective drug. Oral triptans are effective only if you give them in the beginning of a migraine headache. So if the migraine headache is just setting in, you've got the aura before the headache set in, and you give sumatriptan or anitriptan, so it's usually effective. So you can give them orally or nasally, but they say nasal or subcutaneous is preferred because oral is not that much effective when compared to subcutaneous or intranasal one. So oral triptans, remember, if you have to give them early in the course of the migraine attack. Some of the abortive therapies for primary headaches, again, the doses are given. I don't want to go into the details of all these things. Most of them, they are present in the pediatric textbooks, and or in UK we use the BNF for children, and you can see the BNF for children, or you can just consult any book that you're following. You can use doses as long as you adhere to whatever guidelines you are using. Second line treatment, yes, this is an important thing, because many times in hospitals we see, and I'm quoting my personal experience, I see many patients where they have used the first line treatment, they come to the hospital because they cannot get any relief from the first line treatment. So in that case, you need to go for the second line treatment, because obviously they've used the first line and it's not working. So for migraine and cluster headaches, what we normally give as a second line is a normal saline bolus. So you can give a normal saline bolus of 20 mils per kg body weight to a maximum of 1 liter, and to that you can add ketorolac in a dose of 0.5 milligram per kg intravenously, and the maximum dose is 30 milligram. Or you can add prochlorperazine in a dose of 0.15 milligram per kg, going to a maximum of 10 milligrams. Or you can also add metoclopramide instead of prochlorperazine, and the dose is again 0.1 milligram per kg and a maximum of 10 milligrams. But keep it in mind, metoclopramide has got more side effects as compared to prochlorperazine, because dyskinetic reaction, dystonias, things like that are very common with metoclopramide. If you are using metoclopramide, then most of the times you have to use something to mitigate the side effects of metoclopramide, and one of the drugs that I would like to mention, and which is mentioned in Tintin Ali's emergency medicine as well, is diphenhydramine. So diphenhydramine or Phenergon 1 milligram per kg, you can get it intravenously again to a maximum of 50 milligram intravenous, And so this is a cocktail treatment. Like if the first line has failed, so you start with normal saline, you can add to it ketorolac or prochlorperazine or metoclopramide with diphenhydramine. And most of the time they would react to this cocktail treatment and the headache gets better. But if there is no significant relief even with the second line medication, then you have to consider a neurology consultation prior to other therapies, which normally we don't do in emergency medicine, but the consultants in neurology, they can give like some medication like steroid, etc., etc. But usually, I mean, in hospital, most of the time, if the first line has failed, we will give them the second line treatment, and majority of them would respond to that. If they're not responding, then we have to admit them and probably ask for further help from the specialties. As far as tension headaches are concerned, ketorolac is very effective if given parenterally. Again, the dose is 0.5 milligram per kg to a maximum of 30 milligram, and you can add it to acetaminophen, which is paracetamol, as known in this country, 15 milligram per kg to a maximum of 1 gram. As far as prophylaxis is concerned, like obviously, because in primary headaches, usually there is a tendency to have these headaches on a regular basis after some intervals. Some people get it quite frequently. So there are a few prophylactic drugs. Again, they are not guaranteed to work, but they can be tried and tested. And some people, they respond to one type of prophylactic medication, some they respond to another type of prophylactic medication. So calcium channel blockers can be used. Flunarizine and nimodipine are calcium channel blockers which can be used for migraine. You can use beta blocker, and the most time tested is propranolol, 10 milligram twice daily. You can give up to 20 milligram TDS as tolerated, and again the dosages are given here. You can see for less than 14 years we give them 20 milligram twice a day to 120 milligram twice a day as tolerated for those who are greater than 14 years. So beta blockers, propranolol is very effective as a prophylactic medications for migraines. Tricyclic antidepressant, usually people who are not responding to propranolol are usually put on amitriptyline or other tricyclic antidepressants. You slightly have to increase the dose over some time, because there is some sort of a tolerance which develops at lower dosages as you keep on using these medications for a prolonged period of time. So you can start with 10 milligrams orally at bedtime, and you can increase it to a maximum of 50 milligram. And again, depending on the ages, less than 12 years 50 milligram, and for those greater than 12 years you can go up to 100 milligrams. You can use the anti-epileptic medication topiramate, which is also very good for teenagers as a prophylactic medications. And recently there has been a lot of interest in nutraceuticals. So for those with primary headaches, they say the Tintin Ali's Emergency Medicine 20th edition, the pediatric section says, for those who have got frequent primary headaches, trial of daily nutraceuticals is quite safe. And the combination of nutraceuticals that has been tested is a combination of a vitamin B2, which is riboflavin, coenzyme Q10, and melatonin. And they say 400 milligrams per day of riboflavin, that is vitamin B2, added to that 100 to 150 milligrams of coenzyme Q10 per day, and 6 to 12 milligrams of melatonin before bed is quite safe. And they say if you give it on a regular basis, the frequency of tension headaches and migraine headaches goes down. Anyhow, so these are some of the prophylactic medications for primary headaches. So this was all in a nutshell about headaches in pediatric age group. So in this particular lecture, just to summarize, we talked about primary headaches, which is migraine and tension headaches. Migraine, I told you that there are three types of migraine basically. One is migraine with aura, migraine without aura, and a probable migraine. And the international classification of headaches disorders The 2016 version has made clear criteria. So if you've got that criteria with you, if somebody's got headaches, you just ask the questions through going through that criteria, and if it fits them, you can fit them either into migraine with aura, without aura, or if somebody's presenting with less frequent attacks, you can just like classify them as probable migraine. They've got criteria for tension headaches as well. Secondary headaches are more easier to diagnose because the associated symptomatology can guide you towards the underlying cause. Remember, you always, anybody who presents with headache, you always ask about the red flags. So red flags are progressively increasing headaches, a headache which someone mentions that this is the worst headache of their life, headaches which are associated with altered mental status or a low GCS or altered GCS, which is associated or headache which is more worse in the morning, or headache which is made worse by lying down. So these types of headaches, they have to be worked up, and again there are different types of modalities. Usually primary headaches, they do not require any workup. You don't need any scans even if you've got a repeated history, and if you are sure about the diagnosis. Yes, if there are secondary headaches or if there are progressive symptoms and there are other red flag features, then obviously scanning needs to be done. MRI is preferable to CT scan, and again, as I told you, that medications, ibuprofen, paracetamol combination is the best one. Don't use narcotic medications. If second line medications is needed, then saline bolus with parenteral ketorolac or prochlorperazine or metoclopramide with diphenhydramine. This cocktail medication can be given, and this usually aborts most of the migraine and tension headache attacks which are not responding to first line. If the second line also fails, then obviously you have to admit them and refer them to the specialties that they can further look into these cases. And prophylactic medications like propranolol, and recently the nutraceuticals have also been used with some good effects. So if somebody has got frequent attacks, definitely they need to be put on some prophylactic medication so that the overall quality of life is improved. So I hope you have enjoyed today's lecture. If you have got any further questions related to this topic, you can put your question down in the comment section below and I will get back to you with the answer. Thank you very much and have a good day. Bye bye.